Hello and welcome to another episode of the SITREP. Today we're talking different aspect of mental health. We're talking about PTSD, bipolar, therapy, all different types of topics. And today we are joined by Dr. Meg Martinez. Meg, thanks so much for joining us.
Happy to be here. Thanks for having me.
So, topic that is discussed a lot, especially since the early 1980s when it got its name, PTSD, post-traumatic stress disorder. What exactly is it? Because I know it's not the same for everyone.
Yeah. And it's gone through a lot of iterations over time, right? Like in World War I, World War II, we were talking shell shock. Like you said, now in the 80s and later, we're talking post-traumatic stress disorder. So what I generally tell patients is that post-traumatic stress disorder is a particular response to a traumatic incident. And I feel like we tend to throw around that word trauma pretty loosely these days. You know, like you have a really long line at Starbucks and you're like, oh my gosh, that was so traumatic. That's not what we're talking about here. In a clinical sense, we're referring to something really particular, an event where you felt like your life or your personal integrity was in jeopardy, or where you witnessed somebody else's life in danger or being taken. It can include things like being the victim of a crime, like a physical or a sexual assault. It can be things like natural disasters, motor vehicle or other transportation accidents, or it can happen in combat settings where we often think about it in veterans. But it's important to know that it's not just something that happens for people who have experienced combat. It doesn't even need to be an event that happened to you directly. You can experience symptoms of post-traumatic stress when you witness something traumatic happening to someone else, or when you hear about something horrible that's happened to someone that you care about, someone that you're close to, even if you weren't there. It can happen in situations where you are witnessing the aftermath of trauma. So it's really common to see symptoms of post-traumatic stress in first responders, for example. So that is sort of the first requirement for diagnosis of PTSD, is that you have to have experienced a trauma in this sort of particular way that we define it. I want to say, though, that it's not just that. The reality is that most people who have experienced a trauma will not develop PTSD. It's actually the minority of individuals who will go on to develop a post-traumatic stress disorder. Some people may go on to develop other mental health problems like anxiety or depression in the wake of trauma. Many, though, will sort of recover naturally on their own. It never ceases to amaze me in my clinical work how resilient people can be in the face of trauma. We're not talking about that right now, though, although I could talk about that all day. So requirement one for PTSD is that you have to have experienced a trauma. And then there are sort of 4 different symptom clusters that we see in the wake of trauma. So the first are what we refer to as re-experiencing symptoms. So these are sort of what we classically think of when we think of PTSD. You know, we think of like the Vietnam vet who hears the car backfire and he hits the deck. Those sorts of intense physiological or psychological responses to reminders of trauma can be part of the re-experiencing symptoms. But they can also be thoughts or memories or images of the trauma that pop into our head when we don't want to. Nightmares is another really common re-experiencing symptom where you're reliving the traumatic event in some capacity in your dreams. And then there is sort of the more extreme version of re-experiencing, which is what we call a flashback, which is a moment where you are sort of temporarily transported back into that moment. You know, you're no longer in 2025, you're back in, 2003 or whenever it was, sort of reliving that moment as if you were there, as if it were happening in the present. Those actually don't happen all that often. But in order to meet a diagnosis of PTSD, you have to have at least some of those re-experiencing symptoms. So that's cluster 1, re-experiencing symptoms. Cluster 2 are changes in the way that you think and the way that you feel. It's not uncommon after an experience of trauma, right, which is essentially like a huge surge of emotional energy, for people's mood to sort of shift. And it can look different for different people. For some people, that's starting to just feel depressed after something traumatic has happened, just feeling sort of low, sort of apathetic. Other people, they feel really anxious. They feel like they're on edge. You can have people who experience lots of guilt or shame, right? Where they sort of get stuck blaming themselves or blaming somebody else for what happened. We also see that people's thinking can change after a trauma. So it's not uncommon after something traumatic has happened for people to think differently about themselves, right? Like, I can't trust my judgment. I don't have good instincts. Or for them to think differently about other people, right? I can't trust other people. Other people aren't safe. Or to think differently even about the world sort of at large, right? The world is an inherently dangerous place. I can't tell you the number of times I've heard that from my patients. All of those things are sort of representative of that second cluster of symptoms. Okay, so we have re-experiencing symptoms, changes in thinking and feeling. The next cluster are changes in physiological arousal. So people feeling more on edge. So this is another one that is fairly common. Veterans will talk often about hypervigilance, right? And some of that, I think, is just the product of the training you get in the military. It's baked into you. But for veterans who've experienced trauma, for people who have experienced trauma, it persists. So it's not uncommon for folks to say, I'm always looking over my shoulder, right? I'm always, whenever I go into a restaurant, I'm always clocking the exits. If I'm sitting, I never have my back to the door. I want to be able to see all that there is to see, be able to detect the threat. Sometimes people will say that they're more jumpy. They're more easily startled because their body is sort of already on high alert. So any little thing is enough to set them off. We can hear people having difficulty concentrating, so difficulty focusing. The way I often think of that is that, your brain is running this constant threat detection program in the background. And so there just isn't enough mental energy to focus on reading the newspaper or watching that TV show. It's also not uncommon for folks to have trouble sleeping, right? Again, because if you're anticipating the next threat, you're not going to be relaxing enough to get to the point of falling asleep.
It's hard to quiet the mind.
It's hard to quiet the mind. Absolutely. So the important thing to note is that these three symptom clusters, changes in thinking and feeling, changes in physiological arousal, and re-experiencing symptoms, there's nothing pathological about those. That's simply what happens in the wake of something traumatic or stressful. So I use this example with my patients all the time. There was an incident a couple years ago where my daughter fell off a playground structure. She was fine, thankfully, but it was really scary. It was a big fall. And you better believe that when I went to sleep that night and when I closed my eyes, I saw her falling off that playground structure. And every time we went back to that playground for the next couple of times, I felt on edge. Like I needed to be right there with her in case it happened again. So when people experience these symptoms, I think it's important to know that that's not a sign that anything is wrong. It's just a sign of that your brain is trying to make sense of something horrible that happened. Where people run into difficulty, though, is when they have this fourth cluster of symptoms, which are the avoidance symptoms. Avoidance is what makes PTSD a thing, which makes a lot of sense. And I tell this to my patients all the time. Like, do you go around putting your hand on the stove when it's hot?
No.
No, of course not.
No.
Because it's hot and you don't want to get hurt. So it's only natural that we do the same thing to these memories, right? We don't want to go there. This is horrible stuff that we're talking about. Why would you want to think about it or talk about it or remember it? So I think what happens is that people don't, right? They don't want to think about it. They don't want to talk about it. They don't want to remember it.
So it's a form of suppression.
Yeah. And in some situations, is sort of a necessary survival tactic, right? I think about like my combat veterans. If you are still actively in a war zone, you don't have the luxury of thinking about sitting down and processing what happened to your buddy or what happened to you. You gotta swallow it and move on. The trouble is that while that may work in those sorts of environments where you're still actively in a stressful situation, it doesn't promote the sort of healing that we know to be consistent with recovery from post-traumatic stress symptoms. What happens, what we often see is that, people try not to think about it. Right? They don't want to go there. They sort of put it in their mental filing cabinet and say like, oh, we're going to lock that away. We don't want to touch that. And over time, all those little reminders, right? They can be, certain people or certain smells or sounds or certain places, all those things that remind them of the trauma go in that filing cabinet. And this is all well and good, so long as the cabinet stays closed. The problem is that over time, the more you put in that cabinet, the harder it is to stay closed. And the more the contents are likely to pop open like a jack-in-the-box when you don't want them to. This is what really is happening when people are having these re-experiencing symptoms. It's their brain's way of saying like, hey, this happened. Pay attention to this. Like, we need to learn from this. But if you don't open the cabinet, you won't learn.
So Doc, before we go on to management and what have you with regard to PTSD, does frequency of trauma play a role in this? I mean, I understand, I've met people who have been in an auto accident on the highway and they are just like, I'm never getting on a highway again. And they never have.
Yeah.
Right. And that was just one time. But you also have individuals who, veterans who have gone on 13 tours and over half of them are combat tours. So does that play a role in it?
Yeah. So there is some data to suggest that frequency or the number of traumatic incidents one experiences increases the likelihood that you'll go on to develop PTSD in the wake of a trauma. So for instance, for veterans who have done multiple tours, we see that with each and multiple combat tours or tours where they are exposed to traumatic events, they have an increasing rate of PTSD with each tour. But it's not a one-to-one correlation. It's not a perfect science as you're describing, because there are those people who experience all manner of horrible, awful things and escape relatively unscathed. And conversely, there are people who experience one trauma and are really deeply impacted by it. We also know that there is the type of trauma has some impact on the likelihood that someone will go on to develop PTSD. So traumas that are interpersonal in nature, where you're experiencing violence or threat at the hands of another person, are much more likely to turn into PTSD than, say, a natural disaster or an accident.
And so with regard to PTSD, is this something that with proper management can go away? Is there a magic pill, or, what's the deal?
I wish there were a magic pill. Although I suppose if there were a magic pill, I might not have a job. But what I tell patients all the time is that PTSD does not have to be a life sentence. PTSD is actually one of the things that we know how to treat really well. And the next question I usually get is, well, is there a cure for it? And again, the answer depends on what you mean by cure. Like, can I erase these memories permanently from your brain? No, not without major brain surgery, and I definitely wouldn't recommend that. Can I help you make sense of these memories so that you can live in the present and not have your life being dictated by something that happened in the past? Yeah, I can.
Through processing?
Mm-hmm. What I tell everybody, though, is that it involves talking about it. In my experience, the best way out is through. The best way out is to open that filing cabinet in an environment that's safe, oftentimes with the support of a professional, but not necessarily. Pulling out the memories, sort of looking at them in the light of day and starting to come to terms with them in a different way. Getting rid of the pieces that you don't need and everything else filing it away all nice and neat so that it's there, it's in the cabinet. You're not going to forget about it, but it's not popping out when you don't want it to, when you don't need it to.
So Doc, what are some of the ways that we pull those things out of the file cabinet and address them?
Yeah. We have a couple of really great options. These are talk therapies. No medication is required. Many patients will elect to include medications to help manage their symptoms, like the nightmares or the sort of feeling depressed. But what we know is that these talk therapies work regardless of whether or not you're taking medications. So this is the way that I explain it to patients. To sort of understand the rationale for these therapies, it's important to think about our thoughts, our feelings, and our behaviors as all being interrelated. I think about them as being a triangle, right? The apex, each of those is an apex of the triangle. And they're each connected to the other two. So if you want to change one of those things, thoughts, feelings, or behaviors, you can do that by changing one of the other two. Oftentimes when patients are coming into therapy, it's because they want to change how they feel. Right? They're like, I don't want to feel so sad all the time. I don't want to feel so anxious. I don't want to feel so guilty. So the way that we do that when we're treating PTSD is either by changing our thinking about the trauma or by changing our behavior. So the first one on the thinking side of the equation is cognitive processing therapy, or CPT. So CPT is a talk therapy where we are working with patients to identify the ways in which their thinking has been shifted as the result of the trauma. The way in which they think differently about what happened, about what it means about themselves and other people and the world, what it means for their safety, their ability to trust other people, to get close to other people. And what we're doing in CPT is helping people identify these thoughts that are sort of the product of a particular trauma and kind of like put them on trial, is the way I tell patients. Like, we're not just going to take that thought for granted. We're really going to put it under a microscope and examine what is the evidence in support of that thought and what might we be overlooking, with the goal being to come up with a new and more balanced way of thinking about what happened and what it means that serves you better in the present and moving forward. So it really works. And we do that through a lot of sort of written worksheets in which I'm basically teaching my patients how to sort of be their own therapist, how to challenge their thoughts, look at them differently. And the outcome is pretty awesome. So that's the thinking option. The other option is to change the behavior. Right? So as we talked about, the driving force behind PTSD is avoidance. Avoidance of those memories, of thinking about the trauma, avoidance of all the things, the people, the places, the situations that remind you of the trauma. And so to target those, we use a therapy called prolonged exposure, or PE for short. So in PE, we really go after the forms of avoidance that maintain the trauma. And we do that in two different ways. We do that by, number one, having people confront the memory of the traumatic event over and over and over and over.
That sounds scary as hell.
I'm not going to lie, it's not fun, and it really works. And think about it. It makes sense. Like, have you ever seen the movie Jaws?
No.
Are you familiar with the scene in the movie Jaws where they're like, I truthfully haven't actually watched it either, but I know the gist, right? There's the scene where the shark comes out of the water and it eats the boat. The first time you watch that, like, I bet it's scary as hell. That's why I haven't watched it yet.
Yeah.
If you watched that same scene 5, 10, 25, 100 times, do you think you'd jump out of your seat in quite the same way?
No, I'd probably be desensitized to it.
Yeah. That's part of the thinking behind these, what we call imaginal exposures, is that we want people to sort of we want to weaken the power that the memory has over you. And what we see is that is exactly what happens. In fact, I had a patient tell me this just a couple of weeks ago. She said, the memory doesn't have the power over me that it once did. It happened. I know that it happened, but I'm not at its mercy anymore. We also see that as people think about and sort of go through the memory again and again, they start to think differently about what happened. They remember pieces that they didn't remember before, that the sort of the context in which the event happened becomes more clear, and people start to make sense of it in a different way. That maybe it wasn't my fault. Maybe there wasn't anything that I could have done differently.
Perhaps there's some randomness in life and
right.
Just happened to be there.
Right. Wrong place, wrong time. Or maybe just sometimes people do horrible things, that maybe they weren't specifically out for me. Whatever the situation is, people start to come to a different understanding of what happened. That allows them to sort of digest that memory and move on from it. So you're right in that it's not fun. And it's really, really effective. I tell this especially to my veteran patients all the time. Like, you served in the military. You are used to doing hard things. You know how to do hard things. This is a hard thing, and I know that you can do it. So those are the imaginal exposures. As if that weren't enough fun, we then add this other form of exposures, which we call in vivo exposures, or exposures in life. So this is where we ask the person to go out and to confront those situations in the world that have sort of gone into the filing cabinet, to do the things that they have been avoiding doing. And we're not sadists. So I don't just drop you in a Walmart on Black Friday. We work up to it. With each patient, we make a list of their own particular triggers. We sort of arrange them from the least scary to the most scary, and we work our way up ever so slowly at the patient's own pace.
And so I imagine this would be fitting for someone that's not willing to leave the house, or, hard to be in crowds, or all that kind of stuff.
Yep. And the important thing to note is that the data would suggest that these two treatments are equally effective. And I believe that, in my clinical experience, people end up at the same place no matter which of these routes they take. And I'll also just note that these are not the only options. There are a lot of other great options out there. These are just the two that have the most data behind them. And so they're the ones we tend to lead with. The data would suggest, though, that the best predictor of who does well in which treatment is just your preference. The treatment that's going to work for you is the treatment that you're going to do. Both of these treatments require meeting once a week, usually one-on-one. Cognitive processing therapy can sometimes be done in a group, but usually it's done individually. For about 12 weeks, both therapies are for about 12 weeks. Sessions last, on the CPT side of things, usually more like an hour. For PE, they're oftentimes more like an hour and a half. But once a week for 12 weeks with work in between those sessions, right? Because it's not just about the 1 hour, it's about all the other 167 hours of the week. But for people who are willing to put in the work and put in the time, the transformation is incredible.
Doc, thanks so much. And for anybody in the audience that's looking for additional information on this topic, be sure to check out the video description below.
Hey everyone, connecting with your benefits is our primary mission, and the SITREP offers more options than ever. Subscribe to our email newsletter, subscribe to our podcast, or subscribe here on YouTube. For details and links, check out the description below.